Recording and then turn it over to you, David. Oh, David, I meant to ask you, were you satisfied with my answer to your airway question about the aborted or blind ending tracheal bronchus?
Yes, I like that. I like it. It doesn't look like a diverticulum. It does look like as if it's trying to be a bronchus. So it looks like an aborted bronchus attempt.
Yeah, I've seen a few of those where it tries to dive under the azygos, but it just drops out.
Got it.
All right.
So I hope people can see an abnormal chest röntgenogram here with a lumpy thing in the left apex.
We can.
Okay, so that lumpiness there, I would think first of a neural tumor up there. I've seen some people with fluid collections there from torn root sheaths after cervical spine trauma, for instance, from motorcycle accidents at Harborview. So sometimes there have been some fluid collections up there. So let's see what it looks like here on CT. And you can see that it's solid. It has some calcification. It's not liquid. It seems to be paraspinal and then going over the apex. It's not a bad distribution for a neural tumor. Don't see any involvement of intervertebral foramina or anything like that. On coronal, we can see that the calcification is circular here, probably dystrophic calcification. So I would vote first for a nerve sheath tumor of some kind, even though I don't see any connection to the spinal canal. This thing was resected, and what do you think it turns out to be?
Well, knowing you and probably a little bit of gamesmanship here, I'm going to vote for a solitary fibrous tumor. Because you wouldn't just show a nerve sheath tumor.
Okay. Did you like, was nerve sheath tumor what you were anchored on the way I was?
Uh-huh.
Yes, anchoring.
Oh, absolutely. Yep. But okay. I think that I'm guessing, I'm trying to read the poker player here.
Okay, well, it is a solitary fibrous tumor. So congratulations. It is SFT, it's benign. Even though there was, the alarming thing here was the pleural effusion, the accompanying pleural effusion, because this is one of the signs that a fibrous tumor is malignant, is to have an accompanying pleural effusion, and then to have a lot of heterogeneity. So this was not heterogeneous, but it did have a pleural effusion, but still less than 1 mitosis per 10 high-powered fields. So probably benign end of the spectrum of solitary fibrous tumors. So there you go. Unusual location, being high up. They usually are more dependent, but that's what you get in this business. So,
David, have you ever seen one misbehave? You mentioned the signs of, I know they report them to be sort of, they can recur, or they can be more aggressive, but I've probably seen about 30 or so, and I don't think I've ever seen a single one recur.
I have seen the malignant ones, the ones that look bad under the microscope, recur. Mm-hmm. So I know that solitary fibrous tumor can recur. I don't know whether you can distinguish them radiographically ahead of time, which ones will recur. And I don't know how good the microscopy is at predicting recurrence either. Okay. So let me show you this man here, who's a young guy who had already in 2017, at the time of this radiograph, has lowish lung volume and diffuse lung disease here. Looks very, very fine. And things did not get better. So that was 2017. And here's 2021. You can see that he's lost lung volume and that his speckled diffuse lung disease is even more intense than before. And let's go back to 2019 for the earliest CT that we have to show the pattern of this lung fibrosis here. So it's not particularly peripheral, and it is upper lung, worse than lower lung, but it's very widespread. He does have some peripheral sparing here. So and it's upper lung predominant. So if we had to classify this for interstitial pneumonitis, we'd go with NSIP away from a UIP pattern. And things got worse on a more recent CT. So this is, I think this is 2020. This is October, and now you can see that the reticulation is worse. There is no part of the lung that's spared. There's a ground glass even abnormality even down here. There's a lots of traction on the airways and stuff like this. And so, and then he's got pulmonary hypertension too. So he's really got this massively dilated pulmonary artery. He has some lymphadenopathy, but and he's got a little bit, at this point, a little bit of hemomediastinum. I don't think that this was following a procedure. So this could have been spontaneous from his lung fibrosis, maybe popped an airway and had a little Macklin phenomenon going on. So turns out he's got a bad habit. He has smoked, he's vaped 5 milliliters per day for 5 years. So he's a heavy user of vaping products. So far I've been unable to find out what precisely he vaped, but usually when people vape that much, it's marijuana. So this lung fibrosis, the best we know, is probably attributable to his vaping. And I think the distribution with the upper lung predominance, particularly on that earlier CT, when you can sort of see the way things before they'd gotten end stage were distributed, really does support some sort of inhalational kind of injury. So as far as I know, this is, we think this is chronic vaping. So he did get bilateral lung transplant, and the pathologists describe a non-specific kind of fibrosis. They couldn't really pin it to anything. So widespread fibrosis here, probably the result of chronic vaping. Have you guys seen anything like this? We don't see that many vaping cases.
David, how old?
I think around 30.
Wow. Yeah, I think we're going to see more of this. We had that one case that I showed that it was a lady that had a lung biopsy and it was giant cell interstitial pneumonia, and the pathologists attributed it to the cobalt that was, or tungsten that was in her vape pen, because they actually analyzed it at Hopkins, like using mass spectroscopy. But we haven't seen, just fibrosis from vaping, but I bet we will. I mean, I believe this.
Okay. So
that's great.
It's those bad habits.
Dave, do you think that with the vaping, because it's so hot, that maybe some of it's a thermal? I mean, typically thermal injuries hurt the airway mucosa, but this is aerosolized. I forget how hot these things get, but probably a lot hotter than a cigarette. I don't know. I've never vaped or smoked, so I don't know what the difference is. But
I think that, I think that these vaping pens must be designed so that there's not a thermal injury. Because for one thing, I think the amount of heating, it's a very small electrode, I think, that does the heating. And they probably arrange a long pathway so that the stuff cools way out. So I would really doubt that they would design a product that delivered hot gases and the possibility of thermal burn. I mean, this is trying to be a commercial product to appeal to everybody.
Well, I'm just wondering, maybe not that hot, but hot enough that it over time, I don't know. I'm just trying to think, because there's really not any particulates in it. It's predominantly a vaporized liquid or oil.
Yeah. I mean, there are so many chemicals that can be used in these things.
Right. And people have been vaping in Europe for like over a decade, yet we're not, I mean, they didn't even really, I mean, they all thought EVALI was sort of something weird or not. I mean, why weren't they seeing it?
I'll bet you that they have a better controlled market, and they actually know what's in the products rather than just, the Wild West.
True.
Where anything, you put kerosene in there, or, whatever you want.
Okay.
So here's a woman with breast cancer. She's got this kind of abnormal whiteness over the mediastinum here. And on lateral view, you can see that there's actually a soft tissue bulge here. I would never have seen that, but I've got retrospect here going for me. And she had a CT scan, of course, and she's got this huge metastasis here involving her soft tissues and sternum. So this is metastatic breast cancer here, pretty advanced. She's got pleural effusion. She also has pectus excavatum. So she was treated with a new kind of therapy, a new kind of CAR-T cell therapy that's directed against this ROR1 antigen. So this ROR1 antigen is often highly expressed on certain tumors. And there are protocols now for trying this in, it's an autologous T cell transplant with these CAR-T cells in advanced cases of lung cancer and breast cancer, among others. So it's being used for solid tumors. We're used to CAR-T cells for lymphomas and leukemias. So let's go back to that initial chest radiograph. This is baseline. She got these CAR-T cells with this sensitized to this ROR1 antigen, and this is what she looked like a day after she got those CAR-T cells. You can see she's got this diffuse lung disease here. So this is probably some sort of a cytokine reaction. There's accompanying pleural effusion here on the right, probably the left as well. And then this, progressed over a few days, and then was starting to clear by this last radiograph that we have. You can see that the mass is still visible up here. The lungs are cleared. So this is a cytokine reaction to this new kind of CAR-T cell. The thing about this ROR1 antigen is, although it may be highly expressed on certain tumors, it's also expressed on a number of normal body tissues, but just at a much lower rate of expression. So there is going to be some attack on native cells, but they're trying for a therapeutic index with this antigen more highly expressed on tumor cells. And so here's a little NIH protocol statement about this thing. So these cases are from the Fred Hutch Cancer Research Institute in Seattle. So it's modified T cell therapy in treating patients with advanced ROR1, there should be ROR1 malignancies here. And this ROR1 antigen it stands for, let me see, it's in here somewhere. It's the receptor is a tyrosine kinase-like orphan receptor. So I guess this is receptor orphan receptor positive. So ROR1 positive things. And there are certain lymphoid malignancies as well as lung cancers and triple negative breast cancers that are eligible for this new protocol. So I saw a new case yesterday of this ROR1 CAR-T cell therapy, and this person also had just tremendous lung disease that developed overnight as soon as he got this stuff. So it's probably a cytokine release syndrome again, and there's lung edema. It clears fairly rapidly, at least in the couple of cases that I've seen so far. So just beware that, science never stops here, and they keep thinking of new ways to damage people's lungs. So be alert for ROR1 CAR-T cell therapy causing cytokine release. Okay.
Thanks, David. And what was the time frame between the treatment and then the resolution of the radiographic abnormalities?
That was about, we can go back to that. So let's see, the stuff arrived on 4/8, on April the 8th, and it was gone. It was much better on 4/12, which I didn't show, and it was pretty much completely gone by 4/15.
So about a week.
So we're talking about a week.
Okay.
5 days to a week to clear.
Good to know. You can actually see that one of the bone mets on that lateral nicely up there.
Yeah.
Spine.
Yeah, that's
that
right.
ivory vertebral body.
Yeah.
That's right. Okay, thank you.
All right. Thanks, David. All righty. Who would like to go next?
I can go.
All right.
It's been a couple weeks. All right. You should see a portable bedside
Yeah.
Rankinogram here. So this is something I had never seen before, and one that I was about to, actually I'll pull up the comparison. So this one that I'm highlighting is the prior. This is the next one, and I was about to sign it off as unchanged, and then I glanced at the history and it made me rethink my decision. Let you guys look at it for a moment and see if you see any subtle difference.
There's something, is there a gap in the feeding tube?
Yeah, look at that. So the history was evaluate feeding tube after attempt at declog. And sure enough, Peter, you're right, that you can see looks like the thing has exploded. Now, the next question is, do you think that it's completely separated? I was betting that there was going to be at least some piece dangling there. IR did this. I talked to the nurse who had tried to declog it on the floor, and they just took a 10 cc syringe and injected it, and she got a lot of resistance, but then eventually it decompressed. Now, I figured that this was still going to have some strands of tube intact and that they would be able to pull it out. They brought her down to fluoro, and even on the fluoro, and unfortunately I don't have the spot images, but these were already separated further, and this was a couple hours later. So it was completely ruptured, and they were able to pull out this proximal portion and then use the snare, and I was sitting in the control room watching, and they were able to lasso this with a snare and pull it out. And then they saved this so I could take the picture at the end, but this is what the feeding tube looked like. So it had expanded and then just completely burst like a balloon. So, and that was a new one for me and for everyone in IR. Has anybody seen a feeding tube rupture?
Wonder if it was defective or somehow damaged by something.
I mean, it almost looks like a balloon that's popped, right? I think that there was probably the obstruction right near here, and maybe they just forcefully injected and it caused it to blow up. But you're right, maybe there's a little bit of weakness in that wall, but that was a surprise. I will stay on the iatrogenic theme here. Make sure I get the dates right. Let's see what this date is. Yeah, so this is a patient that we were presenting at tumor board, and I was reviewing this, and this was a biopsy-proved adenocarcinoma of the left upper lobe, and it had been biopsied at the outside hospital. And this was pre-op, and this weird tract almost looks like a worm tract, like a case of paragonomyosis. But I thought, given the history, that I thought maybe this was going to be just seeding of the tract, and kind of told the surgeon there that maybe there was a little bit of tumor growing along that, although that was a little unusual given that it looks like a pretty low-grade adenocarcinoma with not much invasive component. And you can see that was not there pre-biopsy. You can see there is just the lesion. It looks like a typical adenocarcinoma. So when they went and took this out, they did just do a wedge, and this was all foreign body granulomatous reaction along the biopsy track. And when I looked in the chart, they had used one of these, which we don't use here. We may test these. I don't know if anyone has used these. It's a Biocentury. This is one of several tract sealing systems, but it's this hydrogel plug that they put in the biopsy along the course of the biopsy needle that's supposed to reduce the risk of pneumothorax. And it's interesting because it says it's tissue-friendly polymer that fully resorbs, but clearly here, this did not fully resorb. So I just thought this was cool that we have like a path correlate for what this actually is the plug along the track of the needle. So if you use something like this, I guess that's something to look out for afterwards. All right, and then I've got two more. And yeah, we'll start with this one. So this is a middle-aged person, and one of my fellows, Maya, saw this on the weekend and made a good observation that she noticed there was something right paratracheal, and noticed there's a little bit of mass effect on the trachea. I will let you guys decide if you see something on the lateral, thinking if it's, well, I'll go back to the PA for a moment, but it looks like there's a normal left-sided aortic arch, so I would have thought maybe this is a mass. There's a little bit of indentation here, maybe a double aortic arch with the mass effect on the trachea, but don't really see anything. Do you guys see anything posterior to the trachea on the lateral view?
No, is
That
there
would,
something overlying it just anterior to that humeral head?
like right there?
Yeah.
Yeah, right. But I was expecting more, we thought maybe if it was vascular, you'd have more indentation. But anyway, so, push comes to shove, she got a CT. Just,
Travis, before
Yeah.
you go to CT, there's an interesting oblique line that goes from the left aortic arch upward toward the right.
Right there?
Yeah. So that's probably a vascular structure, and you can see that with with an aberrant right subclavian artery. So I think this is going to be some sort of a vascular anomaly.
Yeah, you are correct. It is indeed vascular. But what you see it is it's actually a right arch with a left descending aorta, so it's a circumflex aortic arch. And I think, Jeff, what you were pointing out on the lateral must have been where the takeoff of the brachiocephalic or the aberrant left subclavian artery is. And you can even see here the ligamentum arteriosum going from the inferior tip of that left subclavian / arch down to the left pulmonary artery. So, I don't think I've seen a circumflex arch in the last couple of years, but I don't know if she has symptoms referable to this or not. David, I'm curious. It must, maybe this is the line you're seeing, like how that left.
Let's keep scrolling.
Yeah, let's do this. Let's thicken this up and see if it must have been that left subclavian artery. Just like you were saying here. I'll scroll through just on regular. I think that must be what it was. But you're right. So it's the aberrant vessel, just coming off the opposite side. But yeah, that's a good pickup. I hadn't noticed that extra line there. But I think that's probably, or it's that going up to the left subclavian. But anyway, so circumflex aortic arch, incidentally picked up on a radiograph and then on a CT. And then the last case I'll show you is this one. And this is one where this was a couple weeks ago. I saw this radiograph, and this was one that came in overnight. And when I looked at it in the morning, wasn't really sure what was going on because I don't really see an arch at all. Either maybe something here on the right side. I wasn't sure. I looked for rib notching, didn't see any. Noticed that her pulmonary arteries do look a little bit big, so I thought something was funny was going on here. And this patient actually has a history of a trisomy 8 mosaicism, so a very rare one, but certainly associated with congenital abnormalities. So, what's your best?
Travis, there's deviation of the trachea, so that's going to be a right aortic arch.
Right, and that's good. Thank you for reminding me. Yeah, so this one there's also a little bit of mass effect on the trachea, so probably a right arch, maybe a double arch.
The right atrium looks kind of large on that X-ray too.
Yeah, right. And so this one just actually got a CT yesterday, and lo and behold, we have another circumflex aortic arch passing posterior to the trachea and then descending on the left side. This time, though, with conventional arch branching, well, mirror image arch branching, I guess. But yeah, Peter, to your point, and to the point, I'm curious what you guys think, because clearly her pulmonary arteries are huge, and this looks like shunt vascularity. Even her segmental pulmonary arteries are 2 times or more the size of the the corresponding airways. And she's never had an echo, surprisingly, but I feel like there's got to be a secundum ASD right here. Don't really see the septum secundum, and of course it could be that it's just very thin, but you know, her RV is a little distorted by she's got maybe a little bit of a pectus or even a straight back, but you know, so it's not massive. But curious if you guys agree, you think there's some sort of shunt here that's the explanation for her big pulmonary arteries.
Two questions, Travis, and I can't tell.
Yeah.
Sorry. Do you think that could be a double aortic arch with an atretic left segment? That brachiocephalic comes off awfully laterally. Does she have the force vessel sign up high?
Yes, she does.
Well,
maybe
this is a double arch. It's a double arch.
There's a little left ligamentum maybe pulling that.
Travis, can you give us a coronal?
Yeah, maybe you're right.
My other question, Travis, is unrelated but related to anatomy. Does she have two left lungs? I couldn't tell from the.
Yes.
No.
She has two left lungs.
What's that?
She has two left lungs.
No, I looked for that. She has a right upper
axial
lobe.
Crossed.
Yeah.
Okay.
Yeah, no,
Okay.
Yeah, that was definitely one of the things I was wondering even on the radiograph, but maybe you're right. Maybe this is a double arch with an atretic left segment, but still descending on the left side.
Right, and that's typically what they do.
So does that mean, is the circumflex aortic arch really a thing, or is it then that it's just a variant of an atretic segment of a double arch?
No, I think it's a real thing because I've seen cases of it where it just goes up and over and has conventional branching.
But Travis, this coronal is this is perfect location for when you have the left moiety taking off the side of the right aortic arch here, which you have right there. So stop there.
Yeah. Okay.
That's a double arch. So if it's really just a right arch, the brachiocephalic vessels are going to take off on the top of it to get to the neck and the shoulder on the left. But when it's a double arch, they come off the side like this. That coronal is very helpful.
Well, and there you go. And so this is the other patient, and that common carotid comes off the top, and then obviously the aberrant left subclavian comes off in a different place. But so this one you would agree is a circumflex arch. The second one I showed is a double arch with an atretic segment.
I actually, I think that it is a circumflex right aortic arch, this first case.
Yeah.
But I have a 10% question about whether it's really just a form fruste of double arch.
Well,
because
I mean the way you think about the descending aorta embryologically is a different structure than the arch. It's the two dorsal aortic fuse, right? So I think the circumflex is it's which side regresses. In this case, while there's that double arch existing, like one half of one and one half of the other, whereas with the true double arch and atretic segment, you only lose one portion of it, and then it tends to be midline in little kids. When I saw them when I did peds, I saw that they would always descend down the midline, but as the patient got older, they seemed to move more to the right aortic arches, will descend mostly on the right, but they always cross back over with rare exception.
And the thing about the lobar anatomy in this person is that that's a very long right bronchus before it branches. That's unusually long. It takes a long time for that right upper lobe bronchus to come off. So it's thinking about being left, but it didn't really.
And this patient has had a lifelong history of quote unquote asthma. And that reminds me to point out that the big PA she's got malacia of the left main stem bronchus, plus regardless of the nomenclature, and I do agree with you on this case, you're right, this is probably a double arch with an atretic segment. They're both vascular rings, so to a little bit of an extent, it's an academic question because they both can cause symptoms. But yeah, that's a really helpful discussion, like looking at the coronal and seeing where the takeoff of that left-sided moiety is. Cool.
Yeah, those are fun.
gives you a chance to say moiety, which you don't get very often. I love it.
Unless you do kidneys. Oh, and Travis, to your last case, it also has the second congenital anomaly had a nice azygous figure there.
Yes. And yeah, this one also, this is
Yeah.
Caney's law with, I suspect there's a secundum ASD there.
I think you're right. You got to, yeah, I think that was the part we sort of got away from, but yeah, I suspect you're right.
Yeah, with these pulmonary arteries as
They're
large as
huge.
they are. Yeah. All right. Well, thank you. I will stop there.
Those are great. Awesome. All right, Peter, do you have any cases this week?
Yeah, I have a few.
Awesome. Okay, I'll make you presenter. There you go.
This one I'm going to show. I was going to show it last week because I know, Jeff, you showed one of these 2 weeks ago, so I was going to show a companion, but I forgot to show it last week. So it's your case. So this one was a case I saw on one of our tumor boards, and there was concern that this might be a malignancy. It was given in a differential for this nodularity here. To me, this looked like I've seen this a lot, and it looked very much like histo. So it has this beaded appearance here with satellite micronodules, and then they're kind of directed towards the hilum, and you can see calcified nodule here, or calcified lymph node in the left hilum, and then one in the subcarinal, which the left hilum drains into the subcarinal. No calcifications in the spleen, however, so that's the only thing that didn't fit. But regardless, I told them I'm pretty confident this is a endemic fungal infection was healed, and by far we see histo a lot more common than blasto, or we don't see almost no cocci and almost no blasto. And then they wedged this out, and sure enough, it came back histo.
Why'd they wedge it out?
I don't know, because that's what they decided to do. And I guess one report said there was a concern for differential adenocarcinoma.
Unfortunate.
So
I've never seen blasto do this. I've seen histo and cocci do this, but never blasto.
Yeah, exactly. So blasto, from the ones that you've shown, I've seen. I know you always talk about how there's usually no adenopathy also.
Right, and it's usually much uglier looking than just the little histo nodule. But yeah, I mean that's pretty classic. And if you do a PET CT, which hopefully they didn't do, the lymph nodes light up a lot more than the nodule often does.
Yeah, and they recently had in the I think it was 2 months ago, they had a article on endemic fungi. It was a really good article, and they talked about this exact pattern with the bronchovascular beat for histo, bronchovascular beating with micronodules directed towards the hilum. So I thought that was a really good example. And this was very similar to the case you showed 2 weeks ago. I don't know if you remember, right? It's something similar.
The case looks almost like yours.
Yeah, exactly. This one was biopsied. Okay, and then the other two that I have are vascular cases. I will show this one. So this one, the initial scan I'm going to show is post-op from late December of 20. And so this is immediately post-op for repair of a type A dissection. So this is just, I think this is a few days after the surgery. So this is just post-operative blood here. And this is the ascending aortic graft. And then so coming up, they put one, so there's one, I think they did a saphenous, one saphenous vein. So one little bypass there. Just a few little post-op things. This is not a pseudoaneurysm. This is a sewn off side branch graft here. It's very small, but this is a little graft that was sewn off. And then this is a good example of the elephant trunk, the classic elephant trunk, not the frozen elephant trunk. So you have the graft hanging freely in the dissected native aorta, and then here's the intimal flap. Now there's one little thing that I mentioned and I called them about. If you go to the root, so immediately below the root, so this is they also replaced the aortic valve and the root, and so there's a little pseudoaneurysm right there, right below the root. So I've seen in these surgeries, I see tiny pseudoaneurysms at the root or at the attachment sites, relatively commonly. And most of from what I've observed, they're not going to go back and fix something like that, and they don't usually. And usually these things are stable for a long time for follow-up scans. But and I happen to read the follow-up scan for this in April 22nd. This is what it looked like. So I'm showing the gated scan here, but so here's the ascending graft, but this is abnormal. So along the graft, there's this contrast that's coming up, and it stops right there. And then you can see here the side graft, which we saw on the previous scan. But if you go down to the base, so you can see the communication right where that tiny pseudoaneurysm was. So that's pseudoaneurysm, which was iatrogenic, ruptured, and it was held by just adventitia. And then now you just have basically a contained rupture along the ascending graft. And here's the saphenous graft. That's okay. So post-operative complication from a small pseudoaneurysm that became ruptured. And then show one more case, two more actually, but here. This one is from last week also, and there's the patient was imaged within 3 days, was imaged 3 times, but he came in with acute chest pain. And this is the initial CT from, get rid of these. So this is the initial CT, so acute chest pain. So there's soft tissue thickening here in the mediastinum. It looks like it's encasing the pulmonary artery, but it's in the mediastinum, also around the aorta. And then if you go up, it's kind of going around the arch here. A little bit around the vessels also, very subtle. No obvious dissection. And so there was some discrepancy because there was a head and neck CTA, which was read as a vasculitis because they saw this thickening around the vessels here, and this was read in our, we have a separate emergency division, so they read this as a intramural hematoma, which and then the head and neck, I think there was a discrepancy. So the head and neck section just saw the thickening and thought it was a vasculitis. So the patient was imaged the following day again. So I'll show the two, yeah. So the one on the left is from the 22nd, and then the image on the right is the following day. But so if you go to the root again, you can see a tiny abnormality there in the intima, which you can see it also on the day before. So this is not motion artifact. It's there on 2 scans at the same time, and there's mediastinal hemorrhage, which tracks along the sheaths of the pulmonary artery. So this is a tiny intimal tear in the ascending aorta, which has not turned into a frank type A dissection at this point. And the clinical story fit really well. The patient was on 3 antihypertensive medications and came in with really high blood pressures. And then 2 days later, they did a gated CTA. This is a gated CTA, and you can see, again, you see the blood in the mediastinum around the pulmonary artery, and then you can clearly see the intimal tear right there. So I showed back in September, I had one, I was pretty confident about this case because back in September I had a case that was essentially almost the exact same thing. I showed it in September on this conference. So here's the scan from September. So the patient came in. This is a chronic tear, so just kind of ignore this. But again, came in with acute chest pain and with blood in the mediastinum, dissecting along the pulmonary sheaths and even some pulmonary hemorrhage. And then you can see the irregularity here in the ascending aorta. So this is a similar thing. This one was operated and they confirmed there's a tear in the intima. And I've seen one other case which presented acutely like this, and the image 12 hours later, a few hours later, they had this had turned into a type A dissection, a phrenic dissection. So I thought it was a good example of that. And I know you guys have shown some of these before.
Yeah, those are tough, subtle ones. Thanks.
Yeah, some of these can be subtle. Yeah, and I think that's it.
Awesome.
That's all I have.
Okay. All right, I've got just 2 this week. Let me share my screen here. Okay, so this first case is a nice companion with David's, another mass-looking mediastinal type thing here. So there's the frontal. So this patient presented with dysphagia, and here is the lateral. I'm not sure why they don't display right, but you can see this one's got some pretty significant mass effect on the airways here. So this one's located a little bit more anteriorly than David's case. So, and it kind of stops at the thoracic inlet. So in this location with dysphagia, and I forget, the patient was, I want to say, in his 50s. You might think of it's pretty smooth, but and not it'd be unusual for thymoma or lymphoma this far back, but maybe an esophageal mass, although they tend to be more infiltrative and circumferential, and not off to the side, and ectopic thyroid, all the usual stuff. But so he had a CT scan shortly after, and it shows this large mass displacing the trachea, and then you can see there's the esophagus, and there's oral contrast there. So, and there's gas in there, so it seems to be communicating with the esophagus, and you'll see little bits of contrast. So, and it's pretty well circumscribed. So I would think this is probably a diverticulum or a duplication cyst that somehow has gotten bigger and it's communicating. They did a endoscopy, and they did see an ulceration in the mucosa, but this was all mostly, it wasn't a mucosal lesion, as you can tell. And they did a bunch of biopsies, and surprisingly, this came back as a gastrointestinal stromal tumor, which can occur anywhere in the digestive tract. So I pulled an article, and a review article in the surgery literature, but they talk about the esophageal ones are less than 1%, so very, very rare. Luckily, this one was a very low risk, low grade one. And they can be treated with surgery. It's a little trickier. There's a debate about, do you have to do, can you enucleate them, or do you have to do an esophagectomy? This one's really big and had already ruptured. But the important thing is to remove all the disease and remove it intact. And then there's immunotherapy that can be used to treat these as well. It's that a c-KIT mutation in these GI stromal tumors. But I've never seen one in the chest before. This is the first one, and like I said, less than 1%. But somehow this one ruptured, and that's what caused his dysphagia to get worse, as it probably was bleeding or getting infected or something like that. So gastrointestinal stromal tumor of the esophagus. Anyone else ever seen one? I've never heard of one before, so.
Nope, that's impressive.
Yeah, the imaging isn't terribly exciting, but it's another list of esophageal masses or mediastinal masses. So this is just a fun case. This was a patient who has a upper extremity sarcoma and carries a diagnosis of neurofibromatosis type 1 and has some interesting findings. So you'll see there's a couple of, as we go down, you'll see some very subtle holes in the lung, little thin-walled cysts, which have been described in NF1, as has emphysematous looking lesions. I think there were a few down in the bases, nothing terrible. I think people reported fibrosis, but it's unclear if it's related. But he's got a few of those findings. He's got very subtle cutaneous neurofibromas. They're not like the ones that you can see on radiographs. These are more subtle. But as you scroll, you start seeing a bunch of little cutaneous lesions. There's one there. There's another one there. And then he's got some other manifestations as well. He has this big thing here, which, and when you first look at it, you might wonder if this is lymphadenopathy, but that would be weird for a sarcoma. Also, it's very homogeneous, well circumscribed, and just kind of pushing everything out of the way. So I think this is probably a neurofibroma, maybe of the phrenic nerve. The diaphragm is not elevated, but it would be where I'd expect the phrenic nerve to run sort of anterior to the airway there. And then he's got one right here in the intercostal space. I'm sure there's a few other little ones here and there, but no metastatic sarcoma, but just some interesting features. But I liked it for the lung cysts. They are described, but I haven't seen them that often. And it's always confounded because not all, but many of these patients, in my experience, smoke, which you see with a lot of chronic diseases, especially ones that have outward manifestations at a younger age. Patients just seem to have a higher rate of smoking, but I think these little holes probably are from, like right there is probably from the neurofibromatosis. And what causes them, I'm not sure if it's a matrix metalloproteinase disruption or if there's tiny neurofibromas in the lung that obstruct an airway. But this is one of the, I've not seen too many mediastinal ones like this, but that's where I think it's coming from. It's probably phrenic nerve. And that is all I have. So we will end a little early today. So thanks, guys. That was great cases, good discussions. And hopefully Howard will be back next week.
Thanks, everyone.
Yep, take care and talk to you later.
I will be traveling next week, but
all right,
see you guys the week after.
All right, well, safe travels.
Take care.
Take care.
Bye, everyone.
Bye.
Bye-bye.